Hi everybody, this is the second video lecture on the heart. In the previous lecture we outlined the anatomy of the human heart. We also went through the pathway of that blood takes through the heart. In this video we will discuss the intrinsic cardiac conduction system, the electrocardiogram, and also the cardiac cycle. So we learned previously that the heart is able to depolarize intrinsically, meaning that there are no nerves required. The independent but coordinated activity of the heart is the function of two things: the presence of gap junctions and the activity of really the heart's intrinsic or in-house conduction system. This intrinsic cardiac conduction system is a set of non-contractile cardiac cells specialized to initiate and distribute impulses throughout the heart so that it depolarizes and contracts in an orderly sequential manner. As you remember, unstimulated contractile cells of the heart, also neurons and skeletal muscles, maintain a relatively stable resting membrane potential. However, 1% of cardiac fibers are autorhythmic, meaning that they're self-rhythmic. And these are known as cardiac pacemaker cells because they have the ability to depolarize spontaneously and set the pace of the heart. Pacemaker cells are part of the intrinsic conduction system. They have an unstable resting potential that continuously depolarizes, drifting slowly toward the threshold. So these spontaneously changing membrane potentials are called pacemaker potentials or prepotentials. So in this image, you see that the three parts of the action potential in a typical pacemaker cell. So some of the differences that you'll notice with this diagram than the one that you reviewed in skeletal muscle is that the pacemaker potential is due to the special properties of the ion channels in the sarcolemma. In these cells, hyperpolarization at the end of an action potential both closes potassium channels and opens slow sodium channels. The sodium influx alters the balance between potassium lost and sodium entry, and the membrane interior becomes less and less negative, meaning more positive. At step 2, depolarization, the threshold is about a negative 40 millivolts. Calcium channels open, allowing explosive entry of calcium from the extracellular space, and as a result, in pacemaker cells, it is the influx of calcium rather than sodium, as we've seen in skeletal muscle, that produces the rising phase of the action potential and reverses the membrane potential. During repolarization, calcium channels inactivate, as in the other excitable cells. The falling phase of the action potential and repolarization reflect opening of potassium channels and potassium efflux from the cell. And of course, once repolarization is complete, potassium channels close, potassium efflux declines, and the slow depolarization to threshold begins again. Now what we want to do is we want to go through the sequence of excitation. So the typical cardiac pacemaker cells are found in the sinoatrial and atrioventricular nodes. In addition, there are cells of the atrioventricular bundle or the AV bundle, right and left bundle branches, the subendocardial conducting network, also known as the Purkinje fibers, can sometimes act as pacemakers as well. So if we look at the place where we find these cells, they are distributed in these localities or regions within the heart. So we have the sinoatrial node located in the right atrial wall, just inferior to the entrance of the superior vena cava. The SA node typically generates impulses about 75 times every minute. It sets the pace of the heart as a whole because no other region of the conduction system or the myocardium has a faster depolarization state, and that's the reason we refer to this as the pacemaker. From the SA node, the depolarization wave spreads via the gap junctions through the atria and via the internodal pathway to the AV or the atrioventricular node, which is located in the inferior portion of the intraatrial septum, immediately above the tricuspid valve. It should be noted that the impulse is delayed for about 0.1 second, allowing the atria to respond and complete their contraction before the ventricle contracts. So because of this delay, the AV node conducts impulses more slowly than other parts of the system. Next, let's move over to the atrioventricular bundle. So from the AV node, the impulse sweeps to the atrioventricular bundle, also known as the bundle of His, in the superior part of the interventricular septum. Although the atria and ventricles are adjacent to each other, they are not connected by gap junctions. So the AV bundle is really the only electrical connection between them. So note that the AV bundle persists only briefly before splitting into two pathways. It splits into the right and the left bundle branches, which course along the atrioventricular septum toward the apex of the heart. And the subendocardial conducting network, also called the Purkinje fibers, completes the pathway through the interventricular septum, penetrates into the heart apex, and then turns superiorly into the ventricular walls. And the total time between initiation of an impulse by the SA node and depolarization of the last of the ventricular muscle cells is approximately 0.22 seconds or 220 milliseconds in a human heart. So it's important to note that the signal begins with the SA node and it moves along these outlined regions that we just discussed, kind of like a wave effect. And as soon as the signal passes, that's what initiates the cardiac cells to contract. So without the stimulation from the pacemaker cells, then we cannot have contraction of the heart. And the SA node normally drives the heart at a rate about 75 beats per minute. Without the SA node input, the AV node would depolarize only about 50 times per minute. And so the cardiac conduction system coordinates and synchronizes heart activity. Without it, impulses would travel much more slowly. This slower rate would allow some muscle fibers to contract long before others, reducing pump effectiveness. So let's take a look at a homeostatic imbalance. So a defect in the intrinsic conduction system can cause irregular heart rhythms, also known as arrhythmias. They may also cause uncoordinated atrial and ventricular contractions, even fibrillation, which is a condition of rapid and irregular or out-of-phase contractions in which control of heart rhythm is taken away from the SA node by rapid activity in other heart regions. So the heart in fibrillation has been compared with a squirming bag of worms. Fibrillating ventricles are useless as pumps, and unless the heart is defibrillated quickly, circulation stops and death can actually occur. So defibrillation is accomplished by electrically shocking the heart, which is going to interrupt its chaotic twitching by depolarizing the entire myocardium. So you can think of defibrillation as a reset to the SA node with the hopes that it will begin functioning normally and sinus rhythms will be reestablished. So even though we just discussed the intrinsic conduction system sets the basic heart rate, fibers of the autonomic nervous system can modify this beat of the heart and introduce a subtle variability from one beat to the next. The sympathetic nervous system is going to act like the accelerator, which increases both the rate and the force of the heartbeat, whereas the parasympathetic activation, kind of like the brakes, if you will, slows the heart. There are cardiac centers which are located in the medulla oblongata, and the cardiooscillatory center projects to sympathetic neurons within the T1 through T5 level of the spinal cord. So these preganglionic neurons in turn synapse with postganglionic neurons in the cervical and upper thoracic sympathetic trunk. From there, the postganglionic fibers run through the cardiac plexus to the heart, where they innervate the SA and also the AV nodes, the heart muscle, and the coronary artery. The cardioinhibitory center, on the other hand, sends impulses to the parasympathetic dorsal vagus nucleus in the medulla, which in turn sends inhibitory impulses to the heart via branches of the vagus nerve. Most parasympathetic postganglionic motor neurons lie in the ganglia in the heart wall, and their fibers project most heavily in the SA and also in the AV node. So the electrical current generated in and transmitted through the heart spread throughout the body and can be detected with a device that a lot of you know of as the electrocardiograph, the ECG, or the EKG, which is a graphic record of heart activity. So an ECG is a composite of all action potentials generated by nodal and contractile cells at a given time. So it's very important to note that the ECG is not, as sometimes we assume, a tracing of a single action potential. Rather, it's a composite of all the action potentials generated by the nodal and contractile cells, as we just discussed. There are 3 waves that we want to look at. Number 1, the first wave is known as the P wave, and the P wave is typically seen on the ECG, which looks something like this, which a lot of you have seen before, I'm sure. Here is the P wave. It represents depolarization of the SA node. And when depolarization of the SA node happens, that means that the atria are going to go ahead and contract. The next major wave on the ECG is the QRS complex. The QRS complex represents ventricular depolarization. So we know depolarization is going to cause the ventricles to contract, while the QRS complex is responsible, or we see that on the ECG that the QRS complex is telling us that the ventricles are contracting. At the same time, the atria are going to relax. They're going to be under repolarization. And then the last wave that we see is known as the T wave, which is ventricular repolarization. At this time, we note on the ECG that the ventricles are in a relaxed state. To record an ECG, recording electrodes are placed at various sites on the body surface. In a typical 12-lead ECG, 3 electrodes form bipolar leads that measure the voltage difference either between the arms, or it could be between an arm and a leg, and 9 from unipolar leads. Together, the 12 leads provide a comprehensive picture of the heart's electrical activity. So besides having the major waves that we just referred to, we also have segments and intervals that we're going to discuss next, and then we can put all of this together. The first interval is the PR interval, which is the time from the beginning of atrial excitation to the beginning of ventricular excitation. So the PR interval includes atrial depolarization and contraction, as well as the passage of the depolarization wave from the rest or through the rest of the conduction system. Let's move over to the QT interval, which this one is the period from the beginning of ventricular depolarization through ventricular repolarization. So recall that the QRS complex happens or is seen on the ECG, which is letting us know that the signal is spreading through the ventricles, causing depolarization of the ventricles. So we begin the Q interval right after the PR interval, because the PR interval happens when you have the passage of the signal as the atria are contracting. Now it's the time for the ventricles to contract. And in the conclusion of the T wave, we see that the ventricles are in repolarization. Therefore, the QT interval marks the beginning from ventricular depolarization through ventricular repolarization. Let's take a look at the ST segment next. During the ST segment of the ECG, this is when the action potential from ventricular myocytes are in their plateau phases. The entire ventricular myocardium is said to be depolarized at this state. So let's take a close look at the sequence of depolarization and repolarization of the heart related to the deflection waves on the ECG tracing. So the first wave we know as the P wave, and this is when the atria depolarize, which is initiated by the pacemaker, the SA node. When the atria depolarize and that depolarization is complete, the impulse is delayed for a slight moment, as we explained earlier, at the AV node. Ventricular depolarization happens next, and this is seen on the QRS complex. And at the same time, atrial repolarization occurs. Ventricular depolarization is complete, and also ventricular repolarization begins, causing the T wave. And you can note that repolarization is slower than depolarization, so the T wave is more spread out and it has a lower amplitude or height than the QRS complex. Because atrial repolarization takes place during the period of ventricular excitation, the wave representing this atrial repolarization is normally obscured by the large QRS complex that's being recorded at the same time. And finally, we see that at this sequence in the steps, ventricular repolarization is complete, so the ventricles relax. And in a healthy heart, the size, duration, and timing of the deflection waves tend to be consistent for the most part. Changes in pattern or timing of the ECG may reveal a disease or damaged heart or problems with the heart's conduction system. For example, an enlarged R wave hints of enlarged ventricles. An ST segment that is elevated or depressed indicates cardiac ischemia, and a prolonged QT interval reveals a repolarization abnormality that increases the risk of ventricular arrhythmias. So now that we've outlined the intrinsic system of the heart, we have been able to detail that on the ECG. Let's talk about the cardiac cycle. So the cardiac cycle includes all the events associated with the blood flow through the heart during one complete heartbeat. Atrial systole and diastole followed by ventricular systole and diastole. These mechanical events always follow the electrical events that we just outlined in the ECG. By definition, the term systole refers to these periods of contraction, and diastole refers to those of relaxation. The cardiac cycle is marked by a succession of pressure and blood volume changes in the heart. Because blood circulates continuously, we must choose an arbitrary starting point from one turn of the cardiac cycle. So we're going to take a look at this image, which outlines what happens in the left side of the heart. We're going to begin with the heart in total relaxation. On the image, we're looking at ventricular filling, which is mid to late diastole. So during this time, pressure in the heart is low. Blood returning from the circulation is flowing passively through the atria and the open AV valves into the ventricles, and the aortic and pulmonary valves are closed. More than 80% of ventricular filling occurs during this period, and the AV valves flaps begin to drift toward the closed position. Now the stage is set for atrial systole. Following depolarization, the atria are going to contract, compressing the blood in their chambers. This causes a sudden, slight rise in atrial pressure, which propels residual blood out of the atria into the ventricles. And at this point, the ventricles are in the last part of their diastole and have the maximum volume of blood they will contain in the cycle. So we call this amount of blood the end diastolic volume. Then the atria relax and the ventricles depolarize. Atrial diastole persists through the rest of the cycle. Let's move over to the second phase of the cardiac cycle, which is ventricular systole. During ventricular systole, the atria relax, the ventricles begin to contract, their walls close in on the blood in their chambers, and ventricular pressure rises rapidly and sharply, closing those AV valves. For the split second period when the ventricles are completely closed chambers and the blood volume in the chambers remain constant as the ventricles contract, this is known as the isovolumetric contraction phase. Ventricular pressure continues to rise when it finally exceeds the pressure in the large arteries issuing from the ventricles. The isovolumetric stage ends as the SL valves or semilunar valves are forced open and blood rushes from the ventricles into the aorta and pulmonary trunk. During this ventricular ejection phase, the pressure in the aorta is normally reaching at about 120 millimeters of mercury. Let's move over to the last phase, which we know as the isovolumetric relaxation or early diastole. During this brief phase following the T wave, the ventricles are going to relax because the blood remaining in their chambers, referred to as the end systolic volume, is no longer compressed. Ventricular pressure drops rapidly and blood in the aorta and pulmonary trunk flows back toward the heart, closing the semilunar valves. Closure of the aortic valve raises aortic pressure briefly as backflowing blood rebounds off the closed valve cusps, which on the diagram we noted as the dicrotic notch. And two important points that we must remember is that blood flow through the heart is controlled entirely by pressure changes, and number two, blood flows down a pressure gradient through any available opening. The pressure changes therefore reflect the alternating contraction and relaxation of the myocardium and causes the heart valves to open, which keeps blood flowing in the forward direction. Another important thing to note is that the situation in the right side of the heart is essentially the same as in the left side, except for pressure. So the pulmonary circulation is a low pressure circulation, as evidenced by the much thinner myocardium that we discussed earlier. So typical systolic and diastolic pressures for the pulmonary artery are about 24 to 10 millimeters of mercury, compared to systolic and diastolic pressures of 120 and 80 millimeters of mercury, respectively, for the aorta. So, however, the two sides of the heart eject the same blood volume with each heartbeat. Finally, before we move on to the last part of our chapter, we need to talk about the heart sounds. So a lot of you know that auscultating or listening to with a stethoscope reveals two sounds during each heartbeat. A lot of us know those as the lub-dub, lub-dub. So these heart sounds are often described in association with the heart valves closing. So when you hear the lub, which is the first sound of the heart, that is going to be the closing of the AV valves. The dub sound that follows is going to be the closing of the semilunar valves. And blood flows silently as long as its flow is smooth and uninterrupted. If blood strikes obstructions, however, its flow becomes turbulent and generates abnormal heart sounds called heart murmurs that can be heard with a stethoscope. Heart murmurs are fairly common in young children and sometimes in the elderly as well, with perfectly healthy hearts, probably because their heart walls are relatively thin and vibrate with rushing blood. Most often, however, murmurs indicate valve problems, meaning that an insufficient or incompetent valve fails to close completely. There is a swishing sound as blood backflows or regurgitates through the partially open valve after the valve has supposedly closed. A stenotic valve fails to open completely, and its narrow opening restricts blood flow through the valve. In a stenotic or aortic valve, for instance, a high-pitched sound or click can be detected when the valve should be wide open during ventricular contraction, but it is not. And you can probably go on YouTube and just look up heart murmurs, and you'll be able to hear the difference between the typical common lub-dub sound and more of a swishing sound that occurs. So the last part of our cardiovascular physiology, the heart anyway, has to do with cardiac output, which is the amount of blood pumped out by each ventricle in 1 minute. It is actually the product. So cardiac output is the product of heart rate and stroke volume. A lot of you know what heart rate is, but what is stroke volume? By definition, stroke volume is defined as the volume of blood pumped out by one ventricle with each beat. In general, stroke volume correlates with the force of ventricular contraction. Now, normal resting values for heart rate would be about 75 beats per minute, and stroke volume would be about 70 milliliters per beat. the average adult cardiac output can be computed using this equation. The normal adult blood volume is about 5 liters, which is a little more than about a gallon. So as you can see, the entire blood supply passes through each side of the heart once every minute. And another thing that you should notice is that cardiac output varies directly with stroke volume and heart rate. So this means that cardiac output increases when the stroke volume increases or the heart beats faster or both. And cardiac output is going to decrease when either or both of these factors are also going to decrease. Cardiac output is highly variable and increases in response to special demands, such as when we're late for class or we're trying to catch a bus. So the image that you see here are going to be some of the factors that are responsible for affecting stroke volume and heart rate. And remember that when stroke volume and heart rate are affected, it's directly going to affect the cardiac output. So let's take a look at some of these factors. So how can we regulate stroke volume? So if we look at this mathematically, stroke volume represents the difference between end diastolic volume, or EDV, which is the amount of blood that collects in a ventricle during diastole, and end systolic volume, or ESV, is the amount of volume of blood remaining in a ventricle after it has contracted. End diastolic volume, therefore, is affected by length of ventricular diastole and venous pressure, whereas end systolic volume is affected by arterial blood pressure and the force of ventricular contraction. So looking at the equation, we see that normally EDV is going to be 120 milliliters, whereas ESV is going to be approximately 50 milliliters. So in order to figure out the stroke volume, we would just plug in these two numbers, 120 milliliters and 50 milliliters, right? Subtract those, and then we get 70 milliliters. So each ventricle pumps about 70 milliliters of blood with each beat, which is about 60% of the blood in its chambers. So stroke volume, therefore, is going to be regulated or affected when both end diastolic volume and end of systolic volume are affected as well. So there are 3 important factors that we're going to discuss, which are preload, contractility, and afterload. So in the next few slides, we're going to see that preload affects end diastolic volume, whereas contractility and afterload are going to affect end systolic volume. So let's take a look at the first one, which is preload. Preload, by definition, is going to be the degree to which cardiac muscles are stretched just before they contract. So preload then is going to control stroke volume. In a normal heart, the higher the preload, the higher the stroke volume. And this relationship between preload and stroke volume is called the Frank-Starling law of the heart. And cardiac muscles, like skeletal muscles, exhibit a length-tension relationship. Resting skeletal muscle fibers are kept near optimal length for developing maximal tension, while resting cardiac cells are normally shorter than optimal length. So as a result, stretching cardiac cells can produce dramatic increases in contractile force. The most important factor that affects stretching cardiac muscles is venous return, which is the amount of blood returning to the heart and distending into the ventricles. So anything that increases venous return is going to thereby increase end diastolic volume, and consequently, that's also going to increase stroke volume, which is going to act on cardiac output. So one way we can explain this would be, for example, both exercise and increased filling time increase in diastolic volume. Exercise increases venous return because both increase sympathetic nervous system activity and the squeezing action of the skeletal muscles compress the veins, decreasing the volume of blood they contain and returning more blood to the heart. During vigorous exercise, therefore, stroke volume can double as a result of increased venous return. Conversely, when you have low venous return, this might result from severe blood loss or an extremely rapid heart rate that does not allow time for ventricular filling. Low venous return, therefore, decreases end diastolic volume, causing the heart to beat less forcibly and lowering the stroke volume. So the next factor which is affecting stroke volume is going to be contractility. End diastolic volume is the major intrinsic factor influencing stroke volume, but extrinsic factors that increase heart muscle contractility can also enhance stroke volume. Contractility, by definition, is defined as the contractile strength achieved at a given muscle length. So by looking at this image, we see that contractility is independent of muscle stretch and end diastolic volume. Contractility rises when more calcium enters the cytoplasm from the extracellular fluid and the sarcoplasmic reticulum. So therefore, enhanced contractility means more blood is ejected from the heart, thereby greater stroke volume, hence a lower end systolic volume. Also, increased sympathetic stimulation increases contractility. So as noted, sympathetic fibers serve not only the intrinsic conduction system, but also the entire heart. One effect of neuroepinephrine or epinephrine binding is to initiate the cyclic AMP, the secondary messenger system that increases calcium entry, which in turn promotes more cross-bridge binding and also enhances ventricular contractility. And there could be other chemicals as well that can influence contractility, and these are known as positive inotropic agents. And ino or ino just means muscle and fiber. The hormones epinephrine, thyroxine, and glucagon can also have high levels of extracellular calcium that are all positive inotropic agents. Negative inotropic agents, which impair or decrease contractility, include acidosis, or having excess of protons, rising extracellular potassium levels, and drugs called calcium channel blockers as well. So let's move over now to the last factor affecting stroke volume, which is afterload. And afterload, by definition, is the pressure that the ventricles must overcome to eject blood. It is essentially the back pressure that arterial blood exerts on the aortic and pulmonary valves. And that's about 80 millimeters of mercury in the aorta and 10 millimeters of mercury in the pulmonary trunk. And in healthy individuals, afterload is not a major determinant of stroke volume because it's relatively constant. However, in people with hypertension or high blood pressure, afterload is important because it reduces the ability of the ventricles to eject blood. Consequently, more blood remains in the heart after systole, thereby increasing end systolic volume and reducing the stroke volume. So going back to our image, we just summarized that end diastolic volume and end systolic volume are going to directly affect stroke volume. We looked at preload or end diastolic volume. We also looked at the contractility, and we looked at the afterload as well. So now what we want to do is just take very quickly before we conclude the chapter, what would be the effects of the nervous system on heart rate? So given a healthy cardiovascular system, stroke volume tends to be relatively constant. However, when blood volume drops sharply or the heart is seriously weakened, stroke volume declines and cardiac output is maintained by increasing heart rate and also contractility. Temporary stressors that we may have are also going to influence heart rate and consequently cardiac output by acting through homeostatic mechanisms, which are induced neurally or chemically and physically as well. factors that increase heart rate are called positive chronotropic. Chrono just means time. And these chronotropic factors and those that decrease heart rate are called negative chronotropic factors. So the autonomic nervous system exerts the most important extrinsic controls affecting heart rate, as shown on this image previously. So when emotional or physical stressors, such as you're scared, you have anxiety, or even exercise for that matter, activate the sympathetic nervous system, sympathetic nerve fibers release norepinephrine to their cardiac synapses. Norepinephrine binds to beta androgenic receptors in the heart, thereby causing the threshold to be reached more quickly or rapidly. As a result, the SA node fires more rapidly and the heart responds by beating faster. And sympathetic stimulation can also enhance contractility and it speeds relaxation. It does this by enhancing calcium movements in the contractile cells. So enhanced contractility lowers end systolic volume, so stroke volume does not decline as it would if only heart rate increased. And just remember that when the heart beats faster, there is less time for ventricular filling, and so a lower end diastolic volume. So now the parasympathetic division is going to oppose sympathetic effects and effectively reduces heart rate when a stressful situation has passed. Parasympathetic initiated cardiac responses are mediated by acetylcholine, which hyperpolarizes the membranes of its effector cells by opening the potassium channels. Because vagal intervention of the ventricles is sparse, parasympathetic activity has little effect on cardiac contractility. And under resting conditions, both autonomic divisions continuously send impulses to the SA node, but the dominant influence is inhibitory. So for this reason, the heart is said to exhibit vagal tone, and heart rate is generally slower than it would be if the vagal nerves were not innervating it. So we've looked at the action of the autonomic nervous system in regulating heart rate. Now let's talk about the chemical regulation of heart rate. We know that chemicals normally present in the blood and other body fluids may influence our heart rate. First, we're going to discuss hormones. We've also talked about epinephrine. So liberated by the adrenal medulla during the sympathetic nervous system activation, epinephrine produces the same cardiac effects as norepinephrine released by the sympathetic nerves. And this is going to, of course, enhance heart rate and contractility. We also have thyroxine, which is a thyroid gland, and it's going to increase metabolic rate and production of body heat. When in large quantities, it causes a sustained increase in heart rate. Thyroxine acts directly on the heart, but also enhances the effects of epinephrine and norepinephrine. Then we can also have ions. Normal heart function depends on having normal levels of intracellular and extracellular ions. Plasma electrolyte imbalances pose some of these dangers. So we're going to look at some of these imbalances, such as hypocalcemia, which is a reduction in calcium blood levels, and this actually depresses the heart. Conversely, above normal levels, which are hypercalcemia, are going to increase heart rate and contractility. Very high calcium levels disrupt heart function and can cause life-threatening arrhythmias. We can also have high or low blood potassium levels, which can be particularly dangerous and arise in a number of clinical conditions. Excessive potassium hyperkalemia alters electrical activity in the heart by depolarizing the resting potential and may lead to heart block and cardiac arrest. Hypokalemia is also life-threatening in that the heart beats feebly and arrhythmically. Now, there are other factors that can regulate heart rate, such as age, gender, exercise, of course, body temperature also have an influence. Resting heart rate is fastest in a fetus, for example, which is about 140 to 160 beats per minute, and gradually Declines throughout life. Average heart rate is faster in females, 72 to 80 beats per minute, than in males, which is about 64 to 72 beats per minute. You can also have some clinical homeostatic imbalances for heart rate. Tachycardia, some of you have heard about that, is an abnormally fast heart rate, more than 100 beats per minute, which can result from elevated body temperature. It could be stress, certain drugs, and even heart disease. Persistent tachycardia is considered pathological because tachycardia occasionally promotes fibrillation. On the other hand, you can also have bradycardia, which is a slow heart rate. So this is slower than 60 beats per minute, and it may result from low body temperature, certain drugs, or sympathetic nervous activation. And finally, let's move over and talk about the homeostatic imbalance of cardiac output, which is congestive heart failure. This is a condition in which the heart is such as inefficient pump that blood circulation is inadequate to meet tissue needs. This progressively worsening disorder reflects weakening of the myocardium by various stages that damage it in different ways. The most common causes of CHF include coronary atherosclerosis, which is essentially fatty buildup that clogs the coronary arteries. It impairs blood and oxygen delivery to the cardiac cells, and as a result, the heart becomes hypoxic and begins to contract inefficiently. Other causes for CHF include persistent high blood pressure, also multiple myocardial infarctions, which a lot of you know those as heart attacks, and dilated cardiomyopathy, which is known as DCM. So as a result, we've already talked about how the heart is a double pump. If the left side of the heart fails to operate, we call this pulmonary congestion, in whereby the right side continues to propel blood to the lungs, but the left side does not adequately eject the returning blood into the systemic circulation. If this condition is untreated, the person can literally suffocate. When the right side of the heart fails, we call this peripheral congestion. So blood stagnates in body organs, and pooled fluids in the tissue spaces impair the ability of body cells to obtain adequate nutrients and oxygen and rid themselves of waste. This results in edema, most noticeably in the extremities such as feet, ankles, and fingers as well. So you can imagine that failure of one side of the heart puts a greater strain on the other side, and ultimately the whole heart fails. A seriously weakened or decompensated heart is irreparable. So the treatment is directed primarily toward number one, removing the excess liquid or leaked fluid with diuretics. A lot of you know what diuretics are now. The second way or treatment would be reducing afterload with drugs that drive down blood pressure. And finally, the third way would be increased contractility with digital or digitalis derivatives, heart transplants, and other surgical or mechanical remedies to replace damaged heart muscles provide additional hope for some of these cardiac patients. So this concludes our physiology of the heart. In the next video, we will begin detailing the anatomy and physiology of blood vessels. So we'll see you in the next one.